All right. Chapter 50, Abdominal Trauma. Two-thirds of all trauma involve blunt abdominal trauma. And I suppose when you're dealing with blunt trauma, the forces are spread out over a wider area and can cause compression, shearing, rapid deceleration, injuries to the contents in the abdomen. Hemorrhage control inside the abdomen is extremely difficult, so recognizing it early is important, and then getting them quickly to a trauma care facility where they can have their hemorrhage control cared for. When you think of what's inside the abdomen, solid organs, we've all been taught, bleed, and there's a lot of solid organs in the abdomen. Your liver, your spleen, your pancreas. In the retroperitoneal space, you have your kidneys, your adrenal glands, and then in the female patient, you have ovaries. And all these solid organs, when damaged, will bleed heavily. Hollow organs, including the stomach, the intestines, the gallbladder, the urinary bladder, and in women, the uterus, they can rupture and then spill their contents into the abdominal cavity or the retroperitoneal space. In any case, when hollow organs spill their contents into the abdominal cavity, it creates an acute abdomen or a peritonitis with the significant distension, rigidity, pain, those sort of things. There's a lot of vessels in the abdomen as well. You've got the aorta and the inferior vena cava. So those vessels can be torn and bleed heavily as well. The abdomen is bound superiorly by the diaphragm, inferiorly by the skeletal structures, and includes the pelvis and the supporting ligaments, the vertebral column posteriorly, and anteriorly you've got your abdominal wall muscles, and then the flank muscles laterally. So that makes up the cavity, which we call the abdomen. And here's just a picture of that where the diaphragm, and you can see the diaphragm there actually on when the diaphragm is in its resting position, is well into the rib cage. And then you have the abdominal cavity, and then you have the pelvic cavity. And often people will include the pelvic cavity as part of the abdominal cavity. Now behind that, you've got the retroperitoneal space. Now we've all been taught the abdomen is divided into 4 quadrants. The right upper quadrant, which houses the liver, the gallbladder, part of the stomach, the right kidney, the colon, and major blood vessels. And then the left upper quadrant, you've got the stomach, the spleen, the pancreas, more colon, and the left kidney. The right lower quadrant, you have the appendix, more colon, the ovaries and fallopian tubes. And in the left lower quadrant, you have colon and the ovary and the fallopian tubes as well. And then this is just again, an example of the what contents are located in the abdominal cavity based on quadrant. The retroperitoneal structures, parts of the duodenum, parts of the pancreas, the kidneys, the ureters, parts of the colon, several vascular structures supplying blood to the kidneys. And then within the pelvis, you have the rectum, the ureters, the reproductive organs, and then the associated nerves and blood vessels. And this diagram is trying to illustrate the inferior vena cava, the esophagus, the kidneys, the abdominal aorta, as well as the edges of the peritoneum. So lots of stuff in the abdomen, and whether it's blunt or penetrating trauma, you may suspect some significant hemorrhage, which is going to be very difficult to control. With open injuries, the abdominal contents are exposed to the outside environment. You can see those with most often penetrating knife wounds, gunshots, those sort of things, but they can occur as a result of blunt trauma as well. Closed injuries, none of the contents are exposed to the open environment. You see those primarily with blunt trauma. Hemorrhage is possible without a peritonitis. The hollow organs are going to spill their contents. The solid organs are going to bleed. But when you're dealing with an abdominal injury, you should have a high index of suspicion for potential injuries of those organs, depending upon which quadrant the trauma occurred in. With blunt trauma, it's going to be a compression force, like if your seatbelt is worn too high above your pelvic cavity, or if somebody strikes you or kicks you in the abdomen, that's a compression force. The anterior portion of the abdomen ceases forward motion, but the internal organs continue to move forward, and the shear and deceleration forces associated with those organs moving forward, many of those are tacked into place, if you will, by ligaments. And those ligaments literally act as cheese graters, and as the weight of the organ hurls forward, the ligament actually slices those organs open, leading to internal hemorrhage and spilling of contents. With a head-on or frontal impact, if you go down and under the dashboard, or if you're thrown forward through the windshield, that can lead to things like a traumatic aortic disruption, liver and spleen injuries, if impaled upon, if your abdomen is compressed upon the steering wheel, and then non-abdominal injuries to include chest and those sort of things that we've already talked about. With rear end impacts, you've got cervical spine injuries, but you can also have a rapid deceleration injury. Again, anytime you have a rapid sudden change in movement, either forward or back, the abdominal contents will shift forward or back, which can cause injuries to the abdomen. Lateral collision, you can have diaphragmatic herniation, you can involve the liver, the spleen, you can have pelvic fractures and rotational forces. As you're spinning around in the vehicle, all is well until the vehicle impacts and the organs are still spinning in a rotational direction as well, and can shear the attachments to those organs right off. Seatbelt, it was designed to be worn on your pelvic girdle to prevent you from being ejected and to prevent you from, starring the windshield. However, if it's worn improperly, you'll often see immediately a bruise across the abdomen, indicating perhaps damage to the internal organs, with significant hemorrhage into the abdomen as well. So the typical injury pattern is, your solid organs like your pancreas, your liver, your spleen, being compressed and rupturing, small bowel being ruptured as well. Kidneys, if the seatbelt, compresses clear against the spinal cord, it can also affect the kidneys. Secondary injuries include motorcycle and bicycle injuries. You have the initial impact, which will cause an injury, and then if the pedestrian or the motorcycle rider is thrown, when they hit the ground, that'll be another impact. With pedestrian injuries, the injury pattern or phases, you've got the car bumper hits the victim, the head, the abdomen, the torso is thrown, and they may go up and land on the dash and the windshield. Depending on their size, they may go down and under the vehicle where they're run over. If they are thrown up and they hit the dash and the windshield, then they'll often bounce off of that and hit the ground. So you have multiple injury patterns with pedestrians being struck by vehicles. Falls, again, falls greater than 3 times your own height can lead to significant trauma of all your body systems. Deceleration injuries can be penetrating. The abdominal area may be involved. You have to take into account the amount of energy transferred, and that's that whole kinetic energy formula where you look at half the mass times velocity squared. And since velocity is squared, the speed is really the the important factor here, because you're only taking half the mass, but you're taking the velocity times itself. So any increase in velocity doubles or quadruples the kinetic energy that your body is exposed to. So the speed of the projectile, as in the case of gunshot wounds, is far more damaging than the weight of the bullet itself. Some assessment findings. Patients with abdominal injuries are often in shock, so an early indicator of shock would be an altered mental status. They may have airway compromise, particularly if they're vomiting. They may be in respiratory distress, particularly if they've had a diaphragmatic herniation. They may have shock with internal hemorrhage, or they may have signs of peritonitis from hollow organs spilling their contents. And as I had mentioned, very rigid, distended, board-like abdomen. You're going to want to treat the immediate life threats, and again, the immediate life threats concern the airway, concern proper ventilation and oxygenation, as well as hemorrhage control. And if the hemorrhage is internal, one of two things are going to happen. These patients are either going to bleed to death or they're going to clot on their own. Now, should they clot on their own, then that's a good thing. And we need to get them quickly to a surgeon to repair what's going on inside the abdomen. If they don't clot on their own, then they potentially can exsanguinate, and that's where rapid transport would be important. You have to conduct an overall assessment of the entire patient because abdominal injuries are typically not isolated. There's usually one or more injuries associated with abdominal trauma, and sometimes the bleeding can be slow enough that there's no immediately apparent life threat. You just have to keep reassessing the patient with abdominal trauma, suspecting that there is a potential for a life threat. And over time, you may start to see, or you might see evolve vital signs that would indicate that they are, in fact, bleeding inside their belly. Your assessment's going to occur en route. It's going to include vital signs and then the techniques that we've been taught to do assessment, which include inspection, palpation, auscultation. Look for that distended abdomen. Look for any external blood loss, any open wounds, eviscerations, impaled objects. And it's important that, certainly when we roll our patient up to move them, that we do examine the back. Percussion is a technique that, you'd have to tap a lot of bellies to know what you're listening to. I've seen it done, of course, in emergency departments by physicians, and it's a crapshoot. Certainly with modern imaging, we're able to tell quickly whether or not there's free blood in the belly. But you can take your hyperextended middle finger on one hand, place it distal interphalangeal joint, or the tip of your finger, firmly against the patient's abdomen, and then with the opposite middle finger, use a quick flick or strike to tap that finger, and then listen to the sound. It may be dull, it may be normal, it may be hyperresonant, and you want to do this until you can identify these three different sounds. Of course, a normal sound would indicate a normal abdomen, a dull sound would indicate full of fluid, and a hyperresonant sound would be full of air. So here's just an inspection. Here's just a picture of percussion. Palpation, you're looking for tenderness, guarding, and also palpating structures outside the abdomen, like the pelvis, the legs, the ribs, to make certain that there's no trauma there. Management for abdominal injuries is surgical intervention. There is no definitive therapy that we can do in the field. If the bleeding continues, and you'll know so because the patient is exhibiting signs of shock and you can't find blood anywhere. If their vital signs continue to show deterioration, then you know that they are continually bleeding. Rapid evaluation and evacuation is your best choice of treatment. Start your IVs en route, give a fluid bolus, and one of three things is going to happen. You give the fluid bolus, they're going to improve. That's going to tell you the bleeding is stopped. You give the fluid bolus and there's sort of an improvement, and then they start to deteriorate, then the bleeding has started up again. You give a fluid bolus and absolutely nothing happens. They continue to deteriorate. That tells you that they're continuing to hemorrhage. Follow your local protocols for trauma, like we do for all trauma. En route, you're going to finish up your ABCs. You're going to begin shock resuscitation, establish IV therapy while you can. I don't know anybody using a pneumatic anti-shock garment in our area. It still is in the PHTLS text, but it's just so controversial that most medical directors have taken them off the truck. So let's look at some specific abdominal injuries. We'll talk first about hollow organs. You can have a duodenal rupture. You'll see this in an unrestrained head-on where there's a direct blow to the abdomen on the steering wheel. You can have blood loss with this as well. You'll have an intraluminal content spillage into the peritoneum. Small and large intestines are most frequently injured, and the contents are going to be irritable to the lining of the abdominal cavity, causing an acute abdomen. The stomach rupture is typically the result of blunt trauma, severe compression of the abdomen. You're going to want to do your ABCs, look for signs of shock. Obviously, if they spill their abdominal contents, all that gastric acid and that partially digested food is going to be quite irritating to the lining of the abdomen, causing distension, guarding, and rigidity. These patients need rapid transport. Solid organ injuries, again, we had already mentioned, can be caused from blunt or penetrating trauma, and the hemorrhage may be significant enough to cause shock, particularly the liver injuries. And again, when during a rapid deceleration, the ligamentum arteriosum or ligamentum teres, one or the other, I think it's ligamentum teres, holds the liver in place. And during a rapid deceleration, the liver rolls forward against that ligament, and it acts like a cheese slicer and slices the liver open. The ligamentum teres that holds the liver in place actually is a remnant of the umbilical cord. Kerr's sign is shoulder pain from blood in the peritoneal cavity, again associated with bleeding into the abdomen. Some critical findings is that distended rigid abdomen, guarding on palpation. They're going to have abnormal vital signs. During inspection, percussion, and palpation, you're going to see the abnormalities, the distended rigid abdomen, the guarding. Manage your ABCs, large bore IVs. If they've got good radial pulses, there's no reason to give them fluid boluses. But if they are absent in radial pulses, give them a fluid bolus and see what happens. Again, you're going to get one of three responses from a fluid bolus. Vascular injuries occur when people are improperly wearing a seat belt. Again, that seat belt can compress the contents of the abdomen against the spine when you slide forward to the point where it may cause laceration of the aorta or the inferior vena cava. Patients will present with signs of hemorrhagic shock. They'll be pale, cool, clammy, rapid heart rate, rapid breathing, diminished or absent radial peripheral pulses. It's just almost a guarantee that if you've got a motor vehicle collision and your patient is exhibiting signs of shock and you can't find it anywhere, it's probably in the belly. Pelvic fractures occur from auto and pedestrian collisions, from motor vehicle collisions, particularly down and under where you strike your knees on the dash and that force is driven up the femurs and causes the pelvic to fracture. Motorcycle crashes. You've got a lot of abdominal structures in the pelvis. You've got the retroperitoneal structures close by. Major blood vessels run through the pelvis. Thoracic aortic tears can be common as well as a result of abdominal aortic tears. So pelvic fractures can carry up to a 50% mortality just because of hemorrhage loss. I think the thing about pelvic fractures that we've not proven yet, but certainly are suspect of, is like all internal hemorrhage. If somebody has fractured their pelvis and they're bleeding into their pelvis, they're either going to exsanguinate to death or they're going to clot. And then we come along and roll them onto their side and push and pull their pelvis to do our assessment, and we disrupt those clots, and then they start to hemorrhage again and die. In one small study, a service had eliminated the log roll, and they were just using a scoop stretcher to stretch up suspected pelvic fractures, and they decreased their mortality rates by 30%. So there might be something we'll see in the future where, compressing the pelvis, no. Rolling them up onto their side if you suspect a pelvic fracture, no. So we shall see. Hemorrhagic shock can be significant with pelvic fractures. You can have severe blood loss from the pelvic veins and the arteries, in addition to other associated injuries. You're going to do your assessment. I'm not a fan of compressing the pelvis. If I'm in a motor vehicle collision, somebody tells me their pelvis hurts, their hip hurts really bad, it's probably broken, if not a deep bruise, and I'm going to gain nothing by palpating that pelvis. If I suspect it's broken, I'm going to splint appropriately. Manage the ABCs, establish an IV. If there's no radial pulse, give them a fluid bolus. And then pneumatic ion shock garments as a splint to splint a possible pelvic fracture. Again, I just think that's way too much manipulation, increasing the risk of continued hemorrhage. Abdominal wall injuries occur from blunt or penetrating trauma. When I've got an injury to the abdominal wall itself, I have to be suspect of potential injuries to the organs underneath that abdominal wall. Much like when you see rib fractures, the rib fractures aren't it's something that's very painful for a person to deal with, but I'm more concerned not about the rib fractures or the flail segment, but the huge pulmonary contusion underneath. Contusions in the abdomen may indicate hemorrhagic shock. If you have penetrating trauma, you have to assume that the penetration goes well into the peritoneum. These patients need abdominal surgery, so they would require rapid transport, treatment for shock en route. If you are dealing with an evisceration, we know, not to stuff those organs back in the belly, but to cover them with a moist, warm dressing and prevent heat loss, because they can lose a lot of heat out of an evisceration from the abdomen. Here is Cullen's sign. Cullen's sign is a superficial edema and bruising, particularly around the umbilicus, and that's an indication of internal hemorrhage. And you'll see this with seatbelt trauma, in particularly when they wear their seatbelt high above their pelvis. Diaphragmatic injuries occur as a result of compression of the abdomen. The abdominal contents can be herniated into the chest cavity. The left hemidiaphragm is most frequently injured because the right, that's different from what I've always been taught. No, that's correct. The left hemidiaphragm is most frequently injured because on the right side you have the liver protecting the diaphragm, whereas on the left side you've got multiple holes running through your diaphragm that allow the major vessels to come down from your chest into your abdomen, and your abdominal contents can herniate right up through those holes into your chest cavity. These patients are going to have a hard time breathing. You're going to give them supplemental oxygen. When you're listening to breath sounds, you're probably going to hear gurgles and pings or active bowel sounds if the abdominal contents are in the chest. These patients need supplemental oxygen, potential assisted ventilations, and transport. Retroperitoneal injuries include those organs in the retroperitoneal space, which are part of the duodenum, the aorta, the kidneys, part of the pancreas. Now, pancreatic injuries can be really nasty, not only from pancreatic enzymes that are released in the peritoneum, which break down organs and tissues, but the pancreas is a solid organ. So if the pancreas is injured, in addition to the enzymes being released into the abdominal retroperitoneal space, causing a retroperitoneal peritonitis, you'll also have a significant hemorrhage. And what you'll see with pancreatic injury is bruising along the flanks, or one flank, particularly the left flank, as that's where the majority of the pancreas is. This hemorrhage can be severe enough to cause shock, so manage your ABCs and resuscitate from shock. Penetrating injuries to the abdomen, again, you're going to have more than one thing injured if you've got a hole in your abdomen. You want to describe the penetrating injury by the size of the hole, the location of the hole. You want to, if there's an impaled object stuck in the abdomen, stabilize that impaled object, manage their ABCs, and shock resuscitation. And I might add, we talk about shock resuscitation. In the past, that used to be, 2 large bore IVs wide open. And today, that's just not the case. You still can start your 2 large bore IVs, but only give fluid boluses if the radial pulses are absent, and try to make sure that the fluid is warm. In addition to that, if your patient can lie flat and tolerate it, keep them lying flat, keep them covered, and keep the back of the ambulance extremely warm. Trauma in pregnancy also can lead to significant abdominal hemorrhage, particularly with abruptio placenta. That's when the placenta separates from the uterine wall after about week 20 of gestation. Not a common presentation, but it can occur as a result of blunt abdominal trauma. The patient's going to have abdominal pain, going to have cramping, going to have uterine pain, uterine tenderness, may actually cause the patient to go into premature labor and develop uterine contractions. And any sort of spotting or bleeding is really suspect for abruptio placenta. You're going to manage the ABCs, treat for hemorrhagic shock. She's at 20 weeks of pregnancy, so she's, greater than 20 weeks, or when we start getting into the third trimester, we have to remember that we can't lie those patients flat. We're going to have to roll her up onto her left side, and if we can't roll her onto her left side, then grab the abdomen itself and displace it to the left so that we take the weight off that vena cava and don't cause hypotension. Premature labor can occur as a result of a fall, a motor vehicle collision. I've actually delivered a baby as a result of premature labor caused from domestic violence, where the mother was kicked repeatedly in the abdomen, and that put her into labor. For the mother's sake, you're going to manage your ABCs. If there's any sort of hemorrhage, you're going to treat for shock. Uterine rupture is extremely rare. It may occur as a result of an improper seatbelt position. The seatbelt would have to be high on the pelvis, strapped across the abdomen. There would have to be a significant rapid deceleration at a likely higher rate of speed in order for that to happen. In those particular cases, when we're dealing with uterine rupture, you want to resuscitate the mother, as in the case of abruptio placenta. The fetus certainly is at risk of demise, but if we resuscitate the mother, we resuscitate the fetus. Genitourinary trauma can involve the bladder, that you'll see with lower abdominal and pelvic injuries, especially if the bladder is full. In that case, the bladder will rupture, spill urine into the abdominal and pelvic cavity, which certainly can lead to an immediate peritonitis with the distension, guarding, rigidity, all that other stuff. You can have external genitalia trauma as well. Burn, lacerated, penetrated, contused. Rarely is external genitalia life-threatening. It should not distract you from your primary and secondary survey, taking care of the ABCs. They may have signs of internal abdominal injury. They may have blood at the urethral medius of the male, with blood coming out of the urethral medius of the male. That would require you to control the hemorrhage, and that's done best with direct pressure. I've seen that, or I've had to do that once. I had a gentleman put a pencil in his penis. For what reason, I don't know, and he slid down a banister, and when he hit his crotch on the ball at the end of the banister, the pencil broke and lacerated the urethra. And of course, he was hemorrhaging out of the penis, so I had my partner grab direct pressure and hold pressure until the bleeding stopped. External genitalia trauma, it's soft tissue, it's very vascular. It certainly could be significant enough to cause enough hemorrhage to develop signs of shock. So if you are seeing that, you're going to control hemorrhage the way you've always controlled hemorrhage. Keep the patient warm, start the IVs. If radial pulses are present, no need for fluid boluses, but if absent, give them a fluid bolus. The kidneys and the ureters can be damaged as a result of a direct trauma to the back or the flank. We see this in football injuries where the kidneys can become contused. They can develop hematomas on them. So when the kidneys are not working properly, the collection of urine is disrupted. You can have ecchymosis at in the retroperitoneal space or the flank. You look at the flank and it's bruised. They may have frank blood in their urine. Again, treatment is supportive, and if shock is present, treat for shock. All right, with that, then we've wrapped up the chapter on abdomen, and I will talk to you soon.